Welcome, everyone. I'm Sarah Pasteur, and I'm a clinically active family physician. My background is in military medicine, academic medicine, private practice, street medicine, and employer-sponsored delivery models. I received my medical degree from Rosalind Franklin University of Health Sciences and a Master's of Healthcare Administration from Trinity University. I currently serve as head of primary care advancement at Elation Health, which is a primary care focused AI powered clinical first EHR. Additionally, I am a proud member of the board of Primary Care for All Americans. On behalf of the board, I'm pleased to welcome you to tonight's Teach In, Learn In Zoom session. Thank you for joining us this evening. With over 1,600 people from 40 states, the District of Columbia, and 350 zip codes, we are reminded of the incredible momentum we are building together to provide primary care to everyone in every American neighborhood and community. Thank you for your dedication and commitment to expanding access to primary care across the country. Now, it is my great pleasure to introduce our moderator for this evening, Jennifer Ajay, and to extend my sincere thanks to all of the presenters for tonight's event. I'd also like to take a moment to thank the PC4AA Zoom committee, as well as John Wright, Patty Armstrong, and Liv Verity for organizing this event. Take it away, Jennifer.
Thank you. Hello, everyone. My name is Jennifer AJ, and I am a fourth-year medical student at Ross University School of Medicine, currently residing in Queens, New York. I want to start by thanking all of you for being here tonight. By joining us, you're helping build a movement, one that focuses on building healthcare for people in every neighborhood and community, primary care for all Americans. If you haven't shared your community yet, please do so in the chat so we can all see who's here as we work together to build this movement. As a quick reminder, please refrain from using professional titles. This space is about focusing on the importance of being here together, engaged in this work, and valuing the ideas and commitments that will ultimately drive this movement forward. Tonight, we're here to both teach and learn from each other. We encourage you to contribute by submitting your questions in the chat throughout the session. Please stay with us until the end of the session when we'll have time for a Q&A and discussion. We'll explore how you can help bring primary care to everyone in your own neighborhood and community. Now, it is my great pleasure to introduce to you our keynote speaker, Steve Martin. Steve Martin is a professor of family medicine and community health at the UMass Chan Medical School, where he is residency faculty. He is board certified in family medicine and addiction medicine. Steve began his medical career as a National Health Service scholar in a rural community health center and a federal prison medical center. Since 2009, he has worked at the Barr Family Health Center in rural central Massachusetts as a primary care provider, and he is the medical director for its office-based addiction treatment program. Steve's clinical and research interests include primary care, oral health, complex care, addiction medicine, chronic pain, diagnostic error, and health disparities. He is the lead author of publications in the BMJ, JAMA, Lancet, Annals of Internal Medicine, and the American Journal of Public Health. He also serves as chair of Massachusetts Medical Society's Oral Health Committee and is a member of the American Society of Addiction Medicine's Quality Improvement Council. Take it away, Steve.
Thank you. Thanks so much, Jennifer and Sarah and all here. And I hope you can hear me okay. We're going to keep my Massachusetts accent suppressed so that I could be understood from all on the call. And I'm just so grateful to people I've known here for a while, people I've known for a few minutes, and inspired by your commitment and also your vision for how primary care can come to neighborhoods and communities, which has not been the historical approach the U.S. has generally taken. So this is, to me, a much more promising approach, and I appreciate sort of centering the context for my presentation in a community. I actually discussed with Michael a few weeks ago that I'm on the school committee for our local public schools in a rural district, and our health insurance costs just went up close to 40% year over year this past year, meaning that we had to lay off one of our librarian and other staff members. And I think we can see here how communities are absolutely affected, both positively and in this case, really pretty negatively, by the healthcare, I hesitate to say system, the healthcare system experience in the US that's really been very detrimental to many people and very profitable to some people. So I've heeded all the advice and direction from your colleagues, and my presentation is really quite short because I would be grateful to hear thoughts from folks here and in your impressions as to how we can continue to build the movement, also how to, in what way to build. So I'm going to share a couple quotations to sort of ground us. This one I find very salient for healthcare and for social services and general humanist perspective in 2025, that we know more than ever the pains and sufferings of the world and our neighbors in the world, but we're less and less able to respond to them effectively. And this is from a mentor and role model from the UK, Iona Heath, a retired general practitioner, who reminds us that it's time that medicine got back to its core task of relieving suffering. And that's, I think, are these two thoughts that I hope can ground our discussion. There's one more person I'd like to quote, and that would be Jesus, who quite a while ago said something that is at the root of my presentation, which is that it is not the healthy who need a doctor, but the sick. Because in the US, what's happened over the last half century is that more and more care in primary care is given to people who do not have symptoms. And this is a complete change in medicine over the last 5,000 years or more, as long as we've had recorded human history. We've never had a situation where primarily asymptomatic people are the primary people who are receiving care. And I'm going to use this to frame, I think I actually don't use capital letters that often, but I use capital letters here for the group because I think this is a grown-up group and asks grown-up questions and approaches things in a grown-up way. And I think that the grown-up problem that we have to be solved is I'll center this in Boston, but it could be in any community. Boston, though, I should mention, has more primary care clinicians than any place outside of Bethesda, Maryland, where NIH is. And yet, in this account from 2023, a patient who's suicidal and pain had been waiting almost 5 months when he could finally get to see a new primary care doctor. His former provider had only seen him twice about a year earlier without referring him after leaving. Person is quoted, "I went through my whole medical history. At the end of the meeting, my doctor said, 'Just so you know, I won't be seeing you again because I'm leaving the practice.' She didn't like primary care medicine." And it wasn't until 2 months later that the health center cleared him for therapy services, and then even then he had to wait 6 to 8 months. The problem that I imagine we're all centered on is, why could this person in the most medicalized state, in the most medicalized country in the world, not get care when he was suicidal and in pain? And unless we can solve that, then I think we will really have not done the work that's needed. And I have some thoughts as to how we can help solve this, though, after a quarter century myself in primary care. One is, the major one is that our time that we spend in primary care is completely different than it was 50 years ago. 50 years ago, we were generally doing acute care, and the development of the idea of chronic disease was just beginning. But this is a figure that we reprinted with the permission of the authors in a recent publication, showing how in current estimates, and this does not include paperwork or note writing or phone calls, just outright recommendations for work would lead to about a 27-hour day for a general practitioner or primary care clinician. And most of this is actually preventive services. And preventive services really doesn't also include or could be combined with chronic disease. But I just want to note that when it's done this way, again, this is a relatively recent naming by virtue of epidemiological findings that is really based on risk factors. And so the risk factors that I'm allude to here could include blood pressure, blood sugar, cholesterol. But what most people don't know, and what medical science doesn't really share that well, is that if you're any given patient being treated by lowering your blood pressure or lowering your blood sugar with type 2 diabetes, your personal probability that you would benefit is about 1 or 2%. So 98% of the time, you will have no benefit from that treatment. You will have harm from it potentially, but no benefit. To reduce your blood pressure from 140, which is now the recommendation from the American Heart Association, there's generally a 0% benefit looking at prior studies. To reduce your blood sugar from type 2 diabetes, the percent benefit is about 2 to 3%. 97% of the time, a given individual will not have any benefit from lowering their blood sugar. And finally, reducing your cholesterol, again, in a low-risk situation, less than 1% of the time will actually help someone. So these are important findings that have been known for decades, and yet these same asymptomatic risk factors continue to encroach on primary care and overwhelm our days. So I thought I'd give a sense of what my day looked like a couple weeks ago. This is over the course of a day or two. So these are just de-identified visits that included a person with unstable housing having a negative impact on their substance use, recent traumatic brain injury from an assault, arterial disease, likely in someone with difficulty walking, person having difficulty working because of their joint pain, someone with severe depression trying to start school. These are the visits. These are actually non-visits in the second column. These are not things I get paid for or my health center gets paid for. But they are a patient who had a biopsy result with recurrent cancer, a homebound patient needing urgent visiting nurse care, and another patient needing hospice care urgently. In addition to the refill requests and nurse notes and portal messages in the medical record and pharmacy letters and peer-to-peer requirements for imaging. So that's what my day actually looks like. That's what primary care looks like or could look like in terms of helping people in need. But if you were to actually look at how I'm incented through the American healthcare system in primary care, I would be incented to do this all day, which would be to move blood pressure or blood sugar down, to have annual physicals, to measure if someone's depressed, not really help them necessarily, to mark that they've had a chronic condition that's been assessed so that their risk score goes up. These are actually the things that are the boxes that get checked for my incentives and the incentives of my institution. And these are completely incongruent with the needs that patients actually have. But because they're more measurable and suffering is not as measurable, is one reason why we do this. It's also much easier to do the last column. It's a hell of a lot easier to do the last column. It just turns out that that's not a really great use of primary care time or expertise. And what's especially tragic, I think, is that it inevitably excludes people from even being in one of these three columns. And so this study was from the NHS, is certainly applicable in the US, which is as you increase the work and the demand on general practice and you have increasing rules of who should be seen and why for different risk factors, you inevitably reduce continuity and you also create a hidden unmet need within a population. And these are people who would especially benefit from medical care and healthcare and primary care, but cannot even get close to even having a visit in primary care, as we saw in our first slide from the Boston Globe. So we're doing a double tragedy of putting time, to my mind, where it's not really that helpful and taking it away from people who really could benefit from our care. And this is a busy slide, I'm sorry, but we took that set of circumstances, which is there's not enough time and there's too much work to do, and just created five natural outcomes that you could create from this. That is, you could only really focus on prevention because that's 14 hours each day, 14 hours each day that I could be focusing on prevention. And if we only did that, we would do a lot of prevention, but we just wouldn't see any people who are sick. In the second column, you could reduce my panel size by 2/3, and maybe I could do all the work, but then 2/3 people wouldn't have a clinician. I could spend less time with patients. I could cut that by 2/3 by talking faster or having visits that are 7 minutes instead of 14 minutes. We could have primary care teams, but if you actually calculate the number of people needed and the expense of doing that, it would rapidly increase both the amount of money we're spending already in primary care and healthcare, but also pull people from other services where they're good, from education or social services, where they could also be doing really important work. Or in our last column, we suggested that really we should really especially prioritize people who are symptomatic and need help. And so in summary, three ideas. One is that we need primary care to be great at helping people who are symptomatic and suffering. And gets to the work I'm especially impressed with and grateful for and inspired by for the Primary Care for All, which is that we need community and public health to be great at helping with prevention. And a couple brief examples include the fact, for example, that from a policy perspective, there's nothing better than helping people with alcohol use disorder than increasing taxes on alcohol. And that is not a medical intervention, but it is actually the only one that reduces death, hospitalizations, ER visits. And this has been shown in Scotland, where they know a lot about alcohol. But you can also imagine public health and community public health happening through town nurses that I hope we can talk about, and vestiges from the past that existed in the US before they were stolen away from organized medicine. So I would just ask us, maybe if you find it of interest, to consider what are some ways that this combination of primary care focusing on people who are symptomatic or suffering, and community and public health focusing on prevention, what are some ways that perhaps this combination could succeed and allow the care that people need in the right setting? Thanks very much. I have a smiley face here at the very end.
Well, I think you certainly have all of us smiling at that presentation. Thank you so much, Stephen, for sharing what you did tonight, and would love to have people come ask questions in the chat as we tend to do. If you have a question or a comment, type it into the chat. We'll keep an eye on that. You mentioned community nursing. You mentioned this idea of these partnerships with prevention. So how do communities get started with that? How do we bring some of this district nursing back? One of my friends from high school is actually my town nurse. It's shared between our two towns. And so it's an interesting conversation of like, what does that role look like and how does it work? Are there any places doing it well? Should communities have a local health department? What are some of your thoughts around that?
Yeah, well, I think this is where we culturally in the US, it's not our style to learn from others, sadly. But none of the world operates like we do. So none of the world has medicalized that we do. And Lauren Taylor and Elizabeth Bradley wrote about this beautifully in The American Healthcare Paradox. And the paradox is, how could you spend so much money in healthcare and have such downright abysmal outcomes? And they showed very convincingly that you can never spend enough on healthcare if you haven't helped people socially and you haven't helped their public health. That will never work. And yet we seem convinced in the US to double down on more healthcare spending and more healthcare delivery, even though it's a losing proposition. And not as just a losing proposition, it continues to suck resources from people who could really use them. And they're worsening. We learned through really terrific reporting on lifestyle medicine. Lifestyle medicine is actually at parity with healthcare costs in the US. Healthcare is about $5 trillion a year or more. lifestyle medicine has now reached close to $5 trillion per year. And this again is essentially, in the words of the author of the book, a luxury good. And so to have $5 trillion going toward a luxury good, in addition to the money in healthcare that's not being used wisely for people who need help, you'd have a catastrophic situation, I think. So what could we learn? We could learn not to do that. It's very hard. I think this is why the community focus of PC4AA is really essential, because it's who's affected, your neighbors, who's affected your family members, who's affected the people you care about, and where do you have some semblance of control? It's your locality. And it also takes away the motive, the profit motive. And I'm hesitant to say profit motive because not-for-profits have been equally captured by making money, as far as I can tell, in the US. And so the motive really could return toward improving health. And once that's the valence, I think that we could all have, then it brings up a natural set of options, which are, what is our policy? What do our policies look like? Why do we have them? But Patty, I'd be interested. I think not many people, including myself, although we are lucky to have one in my part of Massachusetts, also a town or district nurse. I mean, this is a model that has existed historically, and is a natural one that comes to people's homes, comes to senior centers, meets with people after hospitalizations, connects them, helps navigate. They're incredible. They're Jedi masters of community health and are advocates for people who are too often disenfranchised or marginalized from the healthcare system itself. So those are two examples. One is very policy oriented, one's very sort of person oriented in terms of who's doing the work. So I hope that helps a little bit. And
It does, because as we look at this, some of it becomes like, who makes the decision, right? And so that's, is it the community? How much do you lean into experts? How much do you lean into, who decides what kind of prevention communities should be offering to their own residents, right? And do you get there's a lot of, what did we call them recently? TikTok doctors, right? That are out there that, have sort of these ideas or concepts of what should be, promoted through the community. But we also want to lean into, the studies that have been done and the information that's out there, what would survive in what form. Should these decisions, be made as a result of community discussions? Who's showing up to those discussions, sort of thing. Yeah. So with that, I think Pat Tokars just popped into the chat a little bit, asking about your practice in particular. Pat, are you there right now? Do you want to come off and mute and just ask?
Thank you so much for your presentation. It's very stimulating. For those of us who have drunk the Kool-Aid about preventive medicine and trying to keep people healthy and trying to prevent chronic disease, it's a little hard to digest exactly what it is you're saying. And I'm wondering how your approach translates into your actual practice in your office and your clinic, and particularly in your community.
Well, that's a great question, Pat. And if I could sort of fold that in with a couple of points in the chat about how you measure success and what's risk reduction and what's absolute risk reduction. So it turns out that when you present people with relative risk reduction, so for example, statins will improve your health by 30%. That doesn't take into account that the baseline risk might be 1%. So now your risk is 0.6% and it was 1%. And it's very different. So in multiple studies done Dartmouth or internationally, depending on how you couch these statistics, people make incredibly different decisions. And so I made very deliberate use of this idea of personal probability of benefit, because I think it's the most salient for a given individual. Do I want to take this medicine for the next 10 years when my likelihood of benefit is 2%? And that is absolutely, I'd be glad to share all the studies, but they're very clear. We have a very weak data in terms of primary prevention and efficacy. And that's been the case forever because you're working with a relatively low risk population, and any given person has a low risk of an event. And you're having to treat, in the case of the new guidance for blood pressure, almost every single adult American, which on its own would completely overwhelm the primary care system. So when this same formula was looked at in Norway, which is one of the healthier countries in the world, they would have to quintuple their primary care workforce just to take care of hypertension. So I think we've bitten off a hell of a lot more than we can chew in prevention in primary care, and we haven't really taken a cold, hard look at how much benefit we're having and how much money and time we're sucking away from people who are actually sick and suffering. And I guess the simplest way for me to think about it, or offer to think about it, is how about people who are sick and suffering get first dibs on care? And if you're not sick and you're not suffering, you can get in line. But right now we have a system where I definitely see people, half of my patients on my schedule are there for a preventive visit or for asymptomatic risk factor management. And there are people absolutely who are not getting care, as we saw in the Boston Globe article, who are sick and suffering. So I think that's the trade-off that we haven't acknowledged. And it's an important acknowledgement for us to make, because otherwise we will never actually achieve whatever we achieve in primary care for all Americans. It won't really be the kind of primary care that people really are desperate to have. So as to how my own clinic, I'm offering these ideas as someone who's, but I would say that most countries do not look like the US. France does not look like the US. Norway has no annual physical exams. Ireland has no annual physical exams. The whole prevention idea has been, to me, sort of a ruse to help grow parts of the healthcare system that don't need growing anymore. And the countries that don't do prevention in the way we do it tend to be healthier than we are. So unless someone can explain to me how this all happened, this to me is sort of, I don't see the preventive emperor has a lot of clothes, to be honest. So, and this is after a cold hard look at the data. So, but Judy Steinberg, we go way back, I think, and I see your hand up.
Hi. Thank you, Steve. It's really nice to see you, and a very interesting thesis. I'm wondering if we might want to make a distinction between primary prevention and secondary prevention in your thesis. I mean, I could see a public health nurse, a community nurse, or a public health working on primary prevention. But once you have a diagnosis, I mean, don't you think you need to have a primary care provider helping you with that diagnosis?
So diagnoses, interestingly, I mean, goes back to nosology and the entire epistemology of medicine. Diagnoses are created. So blood pressure we all need blood pressure. And in an article we wrote about a decade ago, we made the point you could exsanguinate someone partially and they would have a lower blood pressure, but it wouldn't make them any healthier. And so a diagnosis of hypertension in 1970 is not the same diagnosis we have now. And they're both primary prevention. So primary prevention is defined as this is actually Richard Smith, the former editor of the BMJ and the head of the UN Committee on Chronic Disease, recently wrote an editorial saying it's time to ban the word prevention because prevention has become such a slippery idea. And what are we trying to prevent? And the common endpoints and studies that are given are really soft. So, for example, you mentioned, Judy, this important idea of someone has a diagnosis. Well, if my blood pressure now, currently in the US, is 132, I now have a diagnosis of hypertension. And so should I now get in line at the front of the line in primary care to have my blood pressure of 132 reduced to 128? Which would provide me virtually no benefit, but would take the place of someone who is sick, who needs care. And so primary prevention, as from a strict definition, is meaning there's been no harm done. There's not been a heart attack or a stroke. And so all the numbers I gave were for primary prevention and noted as a low risk situation. But currently we don't have enough of a workforce to do any primary prevention in full and in any significant way. There's actually, I should mention, tertiary prevention also, which is
Mhm.
kind of an after an event. But there is, I want to mention, this is very important for the group to look at, I think, quaternary prevention. Quaternary prevention is preventing harm to people from prevention. And this has been well established over the last 30 years. And one of the major points from quaternary prevention is quaternary prevention always increases inequity, always. All prevention work increases inequity because people who are sick and suffering are not getting care. And so this inequity, we have to really, I think, ask ourselves, is this really what we want? We want people's blood pressure to go from 132 to 128 in a healthcare setting. And so that the gentleman that I showed on the first slide can't get care because he's sick and suicidal and in pain. Those are the trade-offs that we haven't acknowledged. I think we really have to make and consider what's transactional in the care that we offer and what's relational. And primary care should be absolutely relational. And a lot of the care that I'm asked to provide and through recommendations doesn't need me or anyone with much medical training. And so I think we have to really start to separate out what is medical training for. I don't know many medical students or residents or nurse practitioners, PAs, who are so psyched to go to medicine so that they can reduce a A1C from 7.1 to 6.9. That's not why people do the work. And yet that's by far the lion's share of the work that's happening in American primary care.
Thank you, Stephen, so much. There is more in the chat that we will get to in just a minute, but for right now, I'd love to hand it back to Michael Fine, our fearless leader, to just share a little bit more about what's going on in the PC4AA community. Michael? Just need you to pop off mute.
Thank you, Steve, for a stimulating talk, to say the least, and Patty, and thanks for sort of putting new emphasis on the role of communities and what communities do as individual clinicians think about their relationship with patients. I'm going to be really interested to hear a little bit later. Hopefully, Ken Thompson will come off mute and talk a little bit about community psychiatry. There are lots of really potent ideas that are quite new here. On the other hand, the federal government shutdown isn't really news to anybody who's been doing primary care or primary care policy, because from that perspective, the federal government has been shut down for years. The federal government seems to be okay at making deals with multinational corporations, but maybe not so good at figuring out how to get primary care to everyone in every American neighborhood and community. Now, the exciting thing, on the other hand, is what's happening around the country with primary care for all Americans and how we've been working with lots of new communities and doing kind of cool things. We're learning how to help communities build scholarship programs to send their own students to health professional schools and then bring them home to practice. We've been working with town councils to help them understand the importance of getting primary care to their own employees and saving a whole bunch of money by doing that, so that you have money on the in the Pioneer Valley school system to be able to bring that librarian back instead of wasting it on health care insurance that mostly puts money in the pockets of people who have plenty of money already. We're helping communities think about how to start residency programs. I now have come to believe that any place of about 50,000 people ought to have its own residency, because that's the way to train people to from the community and help them stay in the community. I mean, all this stuff adds up to the notion that bringing primary care to everybody turns out to be doable if you roll up your sleeves and start to do it. So, to anybody on this call and to everybody else, actually, just join Wichita, Kansas, or join Queens, New York, or join Richmond, Virginia, or New Bedford, Massachusetts, or Ledyard, Connecticut, or Situate, Rhode Island, and lots and lots and lots of other places, and do it by finding one person. Do a Zoom and then invite others, but start in your hometown, and just make it happen. There's lots of heartbreak out there in the US and internationally. But to quote our introducer, sorry, and our finisher, the amazing Sarah Pastor, just don't agonize, organize. Will help. Jennifer?
Yes, thank you. In 2 weeks, we'll be meeting again. We encourage everyone to invite someone new to get involved in our movement. Mark your calendars for November 4th, where we'll be hearing from Pedja Stolik and People Power Health. We look forward to seeing you then and there. You can register on our website at www.primarycareforallamericans.org, or you can check out our local and state playbook, volunteer, and donate to support our cause. Now, I would like to reintroduce Sarah Pastor, one of our board members, who will talk to you about how you can support Primary Care for All Americans and why your help is important, even if it's only $1 a month.
Well, friends and neighbors, in an era of profound political division, finding common ground can feel like an insurmountable challenge. And yet, as we've been talking about, one issue transcends party lines, ideology, and geography: the health and well-being of our citizens. U.S. healthcare is in crisis, plagued by soaring costs, inequitable access, disparities by race, income, and culture, and outcomes that lag far behind those of other developed nations. And at the core of this crisis lies a deficiency: the lack of access to primary care for millions of Americans. PCPs are the single anchor of reliable truth in a sea of medical misinformation. And this trust is earned over years of continuous care and built on a longitudinal relationship where your PCP sees you as a whole person. Primary care is not just a health service, it is a common good. It is the singular medical discipline proven to reduce healthcare disparities, lower overall costs, and lead to better health outcomes for entire communities. It is the foundational investment that benefits every single American. But primary care is under unprecedented threat, and this is where Primary Care for All Americans steps in. We are a national grassroots movement built on the belief that lasting solutions begin at the local level. We exist to empower state and community work groups to identify and close the specific gaps in primary care access in their own neighborhoods, because each community is unique. We don't advocate for distant policy, we empower direct local action, but we cannot do it alone. Your donation is not merely a charitable gift, it is a direct investment in the stability, security, and well-being of your own family, your neighbors, and your country. In a time of chaos, let us invest in our communities through an effort that unites us. Let us ensure that every American has access to that essential, stabilizing relationship with a PCP. The time to act is now. Join a work group, donate if you can. The nation's health and treasure cannot wait, while millions of Americans and thousands of American communities search in vain for the care they need. PC4AA movement provides a clear roadmap for change, emphasizing the power of local and state level advocacy to drive national transformation. And by organizing community and state level work groups, building coalitions, and engaging policymakers, we can create a healthcare system that works for everyone. This is more than a healthcare issue. It's an opportunity to unite as a nation around a shared cause that benefits all Americans. In a polarized society, primary care can serve as the bridge that brings us together. It is a cause that transcends. Let us seize this moment to create a movement for primary care for all, a movement that will not only transform our healthcare system, but also heal the divisions that threaten to tear us apart. Together, we can ensure that every American has access to the care they need and deserve, building a stronger, healthier, and more united nation. Please visit our website today to join our movement and make your secure donation. Thank you.
Thank you. Thank you, everyone, for joining us tonight. We appreciate every single one of you for helping spread this movement across our nation in order to bring the change you deserve. Please take a minute to complete our survey. The link is in the chat. We want to hear from you. If you want to talk to members of the leadership team, please stay on the call. The board members would like to stay on and hear feedbacks from you to help us grow as a community. Thank you so much, everyone. See you November 4th.
Thank you all. Ken, do you want to come off mute and sort of talk a little bit about community psychiatry? I don't know if you're still on.
I'm here. Can you see me?
There you are.
Hi, Steve.
Great to see you.
Hang on a second. Let me get myself organized here. So, Michael, it's been a little while. It's good to see you all, and I guess I'm just going to speak very briefly since I've been invited to say something as probably the likely only psychiatrist in this group. Just to say a word about, as I've been asked, to talk about community psychiatry and mental health. And I'm just going to frame it this way. I think about 4 to 5% of the dollar that is spent on healthcare in the United States is spent on primary medical care. Somewhere around 6% is spent on mental health. Some fairly significant fraction of that, but not maybe even the majority, is actually spent on community mental health. And then, of course, something like 2% of money is spent on public health related resources. So if you look at the public facing community based services of primary medical care and community mental health, you're looking at maybe something like 10% of the spend, with public health being added on to that, as things that can maybe actually influence the health and well-being of folks. And yet I find it very unusual for primary medical folks and community mental health, community psychiatry folks to be in communication with each other. So I'm betting, and this is why Michael asked me to speak, I'm a rare bird to be here. And that's got to change. We've really got to change. 10% of the healthcare dollar, that starts to be something significant. And maybe we can figure out how to grow it. But if we continue, both of us, to operate at somewhere around 5% and keep our houses separate from each other, it seems like we are missing a really important fact, which is that, to my knowledge, everybody I know walks around with their head attached to their body.
Thanks,
So
Ken.
I'm going to stop there. I have no idea if that's what you wanted me to say, Michael, but that's what I've got to say.
Well, thanks for that. Lynn Blanchett's also on. Lynn, I don't know if you're willing to come off mute and talk a little bit about district nursing and community nursing. But I think that's what Steve was talking about. And it would be lovely to have your perspective. Lynn is one of the leaders of the Rhode Island State Work Group, and has been kind of the major presence in Rhode Island, talking about district nursing for as long as I can remember. But I don't think she's come off yet. So,
Michael, I'm here, and I'm driving home from another meeting, and so I listened to some of this presentation, and I did put some stuff into the chat in response to this evening's speaker, who I know he didn't hear me, but I was cheering loudly from a rural road in Rhode Island for your perspective on the sort of role of primary care providers in the prevention model versus the, where we really need their skill set in the sick and suffering. I really liked that part of it. But, my background as a home visiting and public and community health nurse is this. We used to be those people in the communities, in the homes, doing those developmental and growth screenings for kids, right? And meeting their families where they were and addressing concerns when we identified them. When the shift happened in that population into pediatric offices, we lost all of that opportunity. Really great pediatric practice can identify kids who are not meeting developmental milestones. And unless they're related to some sort of diagnosable medical condition, they have no capacity to start those kids and the family on the path to catch up, right? What's next? Oh, wait for a referral to somebody else who will then have to do some more screening and some more testing. And meanwhile, the child drops further and further behind developmentally. The family is stressed by not knowing what the next steps are. I don't know. That was stolen by primary care in the medical, sort of setting from nursing who were very good at it. And, I keep saying in these conversations, somewhere in here, we really need to frame what is it that we think nursing contributes to this conversation so that everyone can add it into their conversations, right? Are we PCPs? When you say PCP, do you also mean registered nurses or do you just mean nurse practitioners, right? Because until we are an absolute part of this conversation, we have no capacity to change the way we deliver that care.
Maybe until we think about the needs of whole communities and
Right.
then help those whole communities mobilize themselves. Until we get there, we're going to be picked apart over and over again, not
Sure.
just as professionals, but we're picked apart from person to person. To get back to what Sarah was saying, and that kind of gets in the way of us being sort of one people in one community, taking care of each other, which is where I think we all really want to be. We got lots to do, and I don't know how to thank everybody enough for coming on tonight. I'm sorry for kind of surprising Ken and Lynn and some others, but I thought their perspectives, which I know are, and which they put in the chat, are so valuable to make this conversation robust. And thanks again to Steve for being the spark plug.
Yeah, I really
So-
appreciate this conversation tonight. Yeah.
Thanks, everybody.
Thank
We'll
you
see
so
you in a
much.
couple of
Thanks for all
weeks.
you're doing. Thank you. Stay
Yeah.
well. Thank you.
Start a
You're
local
heroes.
work group. That's all I can say in every community. Take care, everybody.
Thank
You're a
you.
hero. Thank you so much.
All right.